I'm going to switch to his right side. When we're talking about scapula, the important things to look out for here are, number one, both inspection and on palpation is the spine of the scapula. And the spine of the scapula can be appreciated as a bony prominence that is somewhat medial and then courses lateral out onto the acromion. Above the spine of the scapula, you have a prominent rotator cuff muscle above the spine known as the supraspinatus. And that would be located right around this area, the supraspinatus, a very important rotator cuff muscle. Below the spine of the scapula, you have the infraspinatus. Below the spine, infraspinatus. It is an external rotator cuff muscle. When we talk about, go ahead and turn around for me again, Sal. Other planes of motion that we need to highlight are at the wrist. If we can go back down to the wrist, would be particular range of motions that we should talk about in terms of total degrees of range. And the numbers aren't really as important as just to get a sense of what is normal range for that individual patient. And a really key component of this, I think, is always to compare range of motion to the opposite side. We always have a saying in medicine that God gave us two so that we can compare one side to the other. Really, when we talk about wrist, we're talking about the sagittal plane motion of flexion as well as extension. So that would be flexion down to about 90 degrees, and extension is a little bit less, to about 70 degrees. We also have what's called radial deviation. Radial deviation is when he would bring his wrist or his thumb closer towards his body in that plane, and then ulnar deviation is out about that way. I can demonstrate that a little bit better if we let his hand drop down to his side. Radial deviation, when he brings his thumb towards the body, is about 20 degrees, and then ulnar deviation at about 55. You can see you get more ulnar deviation than you do radial deviation. The other motion that we highlighted briefly with the elbow was supination and pronation. He's already in a pronated position, and then you can get almost a full 180 degrees motion, which is supination. Each of those are about 90 to, you can get about 90 degree of motion from neutral to supination, 90 degrees of motion from neutral to pronation, for a total of about 180 degrees. The other important thing when talking about inspection of the elbow is something frequently referred to as the carrying angle. The carrying angle is actually formed by the ulna with the end of the humerus, or the end of the humerus, I should say. And frequently it's the angle that is taken if you drew a line between his humerus and his ulna. It would form, and divided that intersection, you would form an angle. Frequently that angle is about 10 degrees. In women, sometimes it's a little bit more, at about 15. Sometimes, particularly in women, if they have an increased carrying angle, that's sometimes referred to as cubital valgus. Nothing that you need to know for now, but just so that you know, men have a little bit smaller carrying angle than women. When we get up to the shoulder range of motion, I think, is very important, because really the shoulder is one of the most mobile joints in the body, probably the most significant in terms of mobility. We talk about sagittal plane motion at the shoulder with flexion, and you can get about 180 degrees. Go ahead and Sal, raise their arm all the way up. You'll get about 180 degrees, and some of that is combined with scapular motion as well, but predominantly glenohumeral. You can bring your arm down, Sal. And let me have you turn about 90 degrees facing the other way. The other motion other than flexion would be extension. And extension is extending behind the body. Again, it's still in the sagittal plane, and we get about 60 degrees. If you have them turn 90 degrees this way for me, Sal. The next plane of motion, as I demonstrated at the beginning of the tape, would be abduction, which is a coronal plane motion, which is out to the side. And you can get about 170 degrees, almost full overhead motion in terms of abduction of the glenohumeral joint. And come on back down. Again, this is coupled with scapular rotation as well. Adduction is kind of a difficult way to describe adduction, but it's basically bringing the arm to the body. You can describe it in this fashion, or more commonly, people describe it in the horizontal or transverse plane, which is bringing the arm across the body. And in terms of the shoulder, this is what we more frequently refer to as adduction, although both motions truly are adduction. The next are rotation. Rotation is a little bit complicated. There's different ways to evaluate for rotations. I personally do it with the elbows at the side, with the elbows bent to about 90 degrees. And then what I frequently ask the patient to do is to try to act like their arms are gates and to externally rotate their arms as much as possible. You can see that he has about maybe 30 or 40 degrees of external rotation in this fashion here. The next way to evaluate would be, the next plane would be internal rotation, which is again a transverse plane motion, bringing the arm to the abdomen. Another way of checking internal and external rotation would be to have the patient put their hands behind their head. So Sal, let me go ahead and have you do this. This is a combination of motions, which is really abduction of the glenohumeral joint as well as external rotation. So that's one combined motion. That's one way to check it. Another way to do it would be to do internal rotation with adduction. And that's by bringing your hands behind in the handcuff position, so to speak. So Sal, why don't you go ahead and turn around for me. If you can bring your hands up on your small of your back. So this would be adduction and internal rotation, which is, again, a combined motion. The last way that I evaluate rotation, come on, turn around again for me, Sal, would be having the arms, once again, in 90 degrees of abduction. And I think this probably is a good way, particularly with the patient supine, is having them lay down. You've stabilized their scapula in this position, and you can have them do internal rotation, kind of like the scarecrow position. Be careful, because sometimes this has caused pain in patients who have impingement syndrome, something you will learn about as a clinical diagnosis, as well as external rotation. This also can be somewhat concerning because if people have an unstable shoulder, you can cause them to have increased symptoms with this. So internal rotation and external rotation is another way that you can do this. We're going to carry on next with screening examination of the